There are a number of reasons. One is that there are some women, for example, who are born without eggs. And if they know from a relatively young age that if they wanted to build a family, they had the option was to either consider adoption or using donor eggs. So that's one aspect where the donor eggs provides a very important service. There are other women who have premature menopause or run out of eggs at a relatively young age. So, strictly speaking, premature menopause is a group of women who are less than age 40 who have gone into menopause. It could be due to ovarian failure. For example, teenage girls may have been diagnosed with lymphoma or other blood disorders when they were young. And even though the chemotherapy was successfully treated the condition, the chemotherapy can also be toxic and destroy their own eggs. So that's another reason. And of course, there are couples who have tried IVF treatment with their own eggs and have been unsuccessful, and therefore perhaps donor egg has been suggested. And of course, there are couples, same-sex couples, who through the use of donor eggs and a surrogate can achieve their nuclear family. So if you look at the right-hand slides, you can see that natural fertility declines fairly rapidly between women in their late 20s, early 30s through to their early 40s. So the chance of a successful pregnancy through naturally shows a rapid decline from women in their mid-20s, early 30s through to early 40s. So the fertility range is relatively limited for human females. And this is also summarized in the bottom graph. This graph actually was published in the New England Journal of Medicine about 25 years ago. And the author of that particular paper is an old colleague and friend of mine. But you can see the drop in IVF success rates, live birth and IVF success rates in the green line. And once you get into your mid-30s, early 40s, you see a rapid decline in success rates. Whereas with donor egg, you see a fairly constant success rates for women from an early age through to their mid-40s. You do see a small decline in success rates related to women who in the older range from say 45 to 50. And that's probably some biological changes which are going on, perhaps with the uterus or woman's physiology, that has a small impact on the success rates with donor egg. But overall, the success rates are highly gratifying when it comes to treatment through the use of donor eggs. Next slide, please. So the process of donor egg treatment, IVF is required because the eggs are frozen and therefore they have to be fertilized with partner's sperm or donor sperm. But the steps are relatively straightforward because the eggs have already been created. So what needs to be done in terms of the commissioning couple or the recipients is hormonal preparation of the lining of the womb, or so-called endometrial priming. Only 2 hormones are required to prime the lining of the womb, and they parallel what normally happens in a natural cycle, which is growth of the lining of the womb through the use of estrogen, followed by, after ovulation, the use of progesterone. And the role of progesterone is firstly to compete with the estrogen, to change the lining over from what is called a proliferative phase to a secretory phase. So progesterone, as the name suggests, is the progestational agent when it comes to pregnancy. And without it, no woman will ever get pregnant. So progesterone not only switches over the lining from a follicular phase to a secretory phase, so the glands in the lining secrete hormones and other components to encourage an embryo to implant. So once you know the lining of the womb is primed, you then take the embryos that are generated from the donor eggs and transfer one to the uterus. Normally, because we use young egg donors, we only ever transfer one embryo at a time, and the chance of pregnancy from a single embryo is somewhere around about 50% per embryo transfer. So that's it. The data is very good on success rates with donor eggs. So if I could have the next slide, please. One of the questions I often get asked, or one of the concerns expressed by the female recipient, is that how much of the baby is going to be part of me because I'm not using my own egg. And I think it's very important to understand that most human beings, from the standpoint of their DNA and their genes, are very, very similar. And if they weren't similar, then it wouldn't be possible for humans to interbreed. So we have our naked DNA, which is the basic building block of life. But when you look more closely at the control of that building block, in other words, the rate of expression of specific genes that are essential for cell life and human development, all that is done through so-called epigenetics, which is another level of control above the gene level, which really influences the development and health of the baby inside the womb, and is also predictive of their longevity. And this is all done through epigenetics. So the woman's environment, the in utero environment, is in effect determined by the crosstalk between the mother and the placenta. And so the epigenetic component is the most essential part for determining, if you will, likeness or otherwise of the growing fetus. So one should never underestimate the influence and impact of the epigenetics on the basic gene network, which we all carry. And that's an essential part of creating life, is the epigenetics. If you don't have epigenetics operating, you will not end up with a healthy fetus. So I think women should be reassured about the role of the uterine environment and the maternal environment in ultimately determining the gene expression profiles of the fetus and the new offspring. Next slide, please. So let's say you've considered the donor egg route, either by your own experiences or test results by another fertility doctor, and you want to learn more, on a one-by-one basis. You would schedule an appointment with one of our consultants or fertility doctor. You will also work with a donor egg coordinator who knows the ins and outs of how the egg bank works and the various packages and the costs of treatment. And we also urge a counseling session. And to some extent, the importance of the counseling session is based on the HFEA, which is the Human Fertilization Embryology Authority that makes the laws in this country regarding fertility treatment. So there are strict regulations regarding the use of donor gametes in the UK, gamete being eggs or sperm. And of course, in some cases, we use both gametes to treat a case with donor eggs. So you need the counseling session to fully understand the regulations regarding the use of donor gametes, be they either eggs or sperm or eggs and sperm together. And so we do urge individuals or couples to have a counseling session so that we can document that they have been fully informed regarding the regulations of the HFEA. And I'll get to that a little bit in a short while. So if I could have the next slide, please. So this provides an outline of a typical treatment cycle, although it's important to understand that there are variations that can be done with all of these steps. And that is part of the conversation that a couple might have or an individual might have with one of the fertility doctors. But in essence, you should think of it as 4 discrete steps, although they can all be broken up into individual phases. You need to, as I mentioned earlier, you need to prime the womb in a sequential fashion with estrogen and progesterone. You then need to thaw the eggs or warm the eggs officially and create the embryos. So the first thing you do is you confirm that the eggs are fertilized normally. We have to use ICSI to fertilize frozen eggs or vitrified eggs because the egg is surrounded by a protective layer called the zona pellucida. The zona pellucida, when you vitrify the eggs, undergoes a chemical change. It's not part of the egg proper, it's a protective layer. A bit like thinking about an hen's egg has a protective layer, but the yolk is inside. The same thing is true of the zona pellucida. It protects the contents of the egg, but is not involved in egg function. When you freeze the eggs, the chemical change in the surface of the zona pellucida prevents sperm from passing through and getting to the egg. So we have to bypass the zona by injecting a single healthy sperm into the egg. Once you know that you have a fertilized egg, you can then culture the embryos. And nowadays we culture embryos to what is called the blastocyst stage, because it selects out the hardiest and healthiest embryos. And then finally you put an embryo back, and then fingers crossed, the successful pregnancy ensues. But in going through this, it's important to recognize that you don't have to follow this pattern because each step is a discrete step. There are some patients, for example, who might come from overseas and use donor egg. And you can, for example, just simply create the embryos first and then store the embryos, then prime the womb when the couple flies into the UK, and then hopefully you achieve a pregnancy at step 4. So steps 1, 2, and 3 can be moved around depending on the desires of the couple. But all are pretty effective ways of achieving a successful pregnancy. But part of the role of the clinician is to discuss the pros and cons of these different approaches. Next slide, please. So this summarizes our overall cumulative pregnancy rate from the purchase of a set number of eggs for a couple, typically 10. And you can see that you do have a slight age change from under 40 to 41, 44 through 44, 49. It's not quite as pronounced as the previous graph, but you do see this drop, this trend downwards. From women aged 40 to 50, the actual drop per year is about 1%. So overall, from 40 to 50, you will see about a 10% drop in success rates as women go from their early 40s to late 40s to 50s. But this is a sort of very brief summary of our efforts over the last 8 years or so, from 2014 to 2022. But these, one can expect these similar cumulative pregnancy rates today. Next slide, please. So there are a number of advantages to choosing frozen eggs. And this, once again, goes back to the previous slide where I looked at options versus step 1 versus 2 versus 3 versus 4, is that the couple have control over their timeline. They can create embryos and know that they have peace of mind by creating the embryos first. That's one way. There are couples who will normally we will perhaps create more than one embryo. And so sometimes you can put one embryo back in a fresh cycle, and then you can freeze or vitrify the remaining embryos, either if the first cycle doesn't work, or if the first cycle does work, there is a possibility of coming back a year or so later and then trying to achieve a second pregnancy. So you have a sibling, a genetic sibling, from the batch of embryos that are created. One thing that needs to be emphasized with donor eggs, and I'm sure that couples who have gone through IVF with their own eggs, is that at the end of the day, the process is biological. In other words, it's not mathematics, it's not a precise science. So you can never predict outcomes. Even with vitrified donor eggs, you can never predict the outcome until you actually fertilize the eggs and then create the embryos. Once you've created the embryos, then we can be a little bit more certain about the likelihood of a successful outcome based upon the grade and quality of the embryos created. But there's a degree of uncertainty, as it is with fresh IVF, women using their own eggs, as to how many embryos you will end up with and the grade of the embryos that are available for transfer, because there is a correlation between embryo grade and IVF success rates, be it with frozen eggs or fresh eggs. Next slide, please. So as I mentioned earlier, there is a legal framework in the UK that controls every aspect of the fertility treatment that we undertake. And one of the important and unique features of the UK regulations is that it does allow children conceived through any donor gamete, be it just sperm alone or eggs in sperm or eggs, that the child does have the right to get more information about the egg donor once they reach the age of 18, in other words, adulthood. Some individuals will go ahead and track down the donor, and usually they're not looking for a replacement parent. They're usually curious as to what motivated people to become donors, be it egg donors or sperm donors. But this is one of the reasons why we do recommend counselling, so that individuals and couples can be fully informed of what to expect if they have a successful treatment cycle using donor sperm or donor egg or both. I find that the counsellors are very, very good at explaining the implications of the HFEA regulations. And of course, it's important to remember that a lot of the counsellors became counsellors because they themselves went through fertility treatment and IVF treatment. So they are very sensitive to the needs and sensibilities of couples nowadays going through the same process because they can share experiences. Next slide, please. And this just reinforces some of the advantages of having ID release of the donors with regard to the recipients, and this makes interesting reading. But I think the main thing is for transparency and respecting the rights and autonomy of donor conceived individuals. So it really follows the basic tenets of good medicine when it's about being informed, being in control, the rights of the individual, and so on. But these are the important factors, I think, and why the UK, I think, to some extent, is ahead of things when it comes to information about the donors with regard to the what's provided to the children conceived through such treatments. Next slide, please. So a little bit about the donors. We accept women between the ages of 18 and 35. If you look at IVF success rates for women under the age of 35, you don't see huge differences in success rates through this age range. If you want to think of it in terms of an optimal age range for an egg donor. It's probably 24 to 30 where the evidence is that the number of viable eggs are probably optimal in that age range. We accept all ethnicities and backgrounds for egg donation as long as they meet all the appropriate criteria. The main criteria are they need to have good ovarian function for egg donation, because we want to try to get a reasonable number of good quality eggs from each egg donor. They have to go through extensive screening. They have to fill in questionnaires, physical data. We need letters of approval from any medical consultants the donors might have used, and their GP surgery. So the rejection rate is quite high, from donors starting off from expressing an interest to actually becoming donors. And it's a relatively arduous journey for the donors. So once they get through to where they do a cycle of egg donation, you can perhaps realize that these are strongly committed individuals who really believe in what they're doing. And I think that's very important for recipients to understand. Next slide, please. So this is a breakdown of some of the reasons why egg donors become egg donors. As you can see, that by far the two largest groups are to help others. I think there's a certain sense of sisterhood amongst women when it comes to use of eggs. And they are aware that some women, for various reasons, don't have eggs of their own and therefore are driven to provide eggs through an egg bank. So that plus individuals watch family members to go through infertility treatment, or themselves had maybe infertility treatment, or the partner had fertility issues. So personal experience and a sense of sisterhood, I think, are the two driving forces for the majority of donors. But there are also women in the late 20s or early 30s who have finished their family building, their nuclear family, and realize that the eggs that they have will no longer be used, and therefore they're willing to share those eggs. So there's a diverse range of reasons, but I'd say the two main ones are to help other women and personal experience in family members who have had gone through fertility treatment, and therefore they feel an urge to want to help. Next slide, please. This goes into a little bit more detail of the hard work that we do in the background when we recruit egg donors. And you can see listed above, it's a medical component, there's a genetic component, there's a counseling session, and working with both the coordinator and a clinician. They have to see both by the egg bank coordinators and a clinician to get a sense that they would be good egg donors. And then beyond that, there's a 3-generation family medical in genetic history, personal education, work interests, and then we have to do extensive screening for infectious diseases, hormone testing, and an ultrasound evaluation of the pelvic anatomy. So there's a lot of stuff that we do in the background before a cohort of eggs appears on the London Egg Bank website. And they have to meet all of these criteria before they can actually do a cycle of egg donation. Next slide, please. There are several levels of interrogation of the website and the database for egg donors, and a lot depends on the stage or commitment of the recipients. they might just go and look at the website out of interest, but not commit. If they commit, then there's a whole level of new information that's provided on the website. And at the same time, recipients will work with the donor egg coordinator, and suggestions would be made. I think the key to working with the egg bank is to make sure that the recipients ask directed questions of the coordinators, learn more about the pricing structures of the different packages that are on offer, so that at the end of the day, the recipients can feel confident that they have truly made an informed choice, and they're satisfied with the information that they've been provided. Next slide, please. So here's a more extensive donor profile that you can see here. That's when you're actually now probing in more detail the medical background of the donors, and so on. And it will price things, but Nicola will go a little bit more into the pricing towards the end of my talk. Next slide, please. And of course, we like pen sketches and goodwill messages that donors will leave for the recipients, when what motivated them to become egg donors. As you can see, that egg donors who eventually become egg donors are really very committed to becoming egg donors, and they've gone through a lot. And of course, women in the audience who have already gone through IVF with their own eggs know what's involved in stimulating the ovaries, the monitoring, the blood studies, and the egg collection. All the donors have to go through that so that we can then retrieve the eggs, check them out for health, and then make sure they're safely vitrified and available in the egg bank. Next slide, please. As I mentioned earlier, we are dealing in a biological process, and it's very important to bear that in mind. So what I presented here is averages, right? So generally, the overall survival rate of a vitrified egg is almost 100%. It's about 90, 97, 98%. So most eggs survive, not all. So if you start off with if you purchase, say, 6 eggs, and they're warmed or thawed, you can probably expect 4, probably more likely 6, to survive the warming process. The overall fertilization rate of a warmed egg is about 70%, 75%. So from those 5 or 6, you might get 3 or 4. Ideally, you still get 6, and that happens in some cases. And then the overall development of a fertilized egg to the blastocyst stage is about 50%. So there are some couples who purchase 6 eggs and we end up with 4 blastocysts. But if the average is 1 or 2 from 6 eggs and someone gets 4, that must mean that some couples got none, if you're dealing in averages. That's not to say that the egg bank doesn't have special programs for couples where they get no embryos, and they certainly do. But that's the sort of conversation that you would have with the donor egg coordinator. But the egg bank does offer very generous packages if a couple's first try at donor egg ends up with no embryos, because the egg bank is interested in success rates, and therefore they will offer a very generous package for a second try. So I think one should be confident that at the end of the day, couples will always have embryos to go back, but precisely how many cannot be predicted beforehand until the eggs have been fertilized by either partner's sperm or donor sperm. Next slide, please. So these are the hard numbers. I'm going to have Nicola, just a couple of slides left. Just going to have Nicola talk briefly about the packages that are available through the service of the London Egg Bank. Thank you, Nicole.
Of course. Thank you for your presentation so far. So before I talk about the costs at the London Egg Bank, I do just want to remind you that we do have a Q&A function on this call. So if you want to write in your question, you are very welcome to do so. We will have some time to go through your questions. I can already see that some people have sent some and some people have sent some directly to me. So thank you for that. Now, the costs that we can see on the slide currently are for treatment in our London clinic. This can vary if you are having treatment in Bristol, Cardiff, or in Darlington, but you can see all of these costs on the London Egg Bank website. And of course, you can speak to us directly if you do want us to let you know. Now, with our standard IVF packages, which are the first two options that we can see, this is for treatment from start to finish. So it includes the cost of your eggs, it includes the cost of your ICSI treatment. So we always do ICSI as a standard procedure. It's not an additional cost at our clinic. And then it includes the cost of your first embryo transfer, which you can choose to be a fresh transfer or a frozen transfer, as well as your aftercare. So your pregnancy blood test and your pregnancy scan, just to confirm the outcome. There are additional costs with our packages, such as medication and any investigations that you choose to do with us. These aren't fixed prices just because we don't know exactly what your medication plan will be. It is personalized to your own medical history so that you can have the greatest success with us. And also with investigations, we are very flexible as a clinic. We know that a lot of patients who come to us have done investigations recently elsewhere, so we can try accept what you already have as far as is possible. Now, with the 2-cycle packages, you may have read about this on our website. These are only available if you're having treatment in London. And with our silver package and our gold package, you do need to assess your eligibility for it first. So what you would need to do is have your doctor's consultation in London initially. If you do not live near London, then that is absolutely fine. You can have this consultation online. How these packages work is they have guarantees in place. So with our silver package and our gold package, it comes with a refund guarantee. So it includes donor eggs from 2 different donors, the batch of 6 initially from your first donor. We would create your embryos, and all of your embryo transfers are included in the price until you have had a live birth. So not just a pregnancy, but a baby from the treatment. If from your first donor, unfortunately, your treatment has been unsuccessful, rather than going from square one, we would move on to donor number 2. Again, we would allocate you a new batch of eggs, you would create the embryos, and you would do the same again. And what's nice about this package is that if at the end of the treatment, unfortunately, you haven't had a live birth, this is when you receive that refund. So on the silver package, the total cost is £22,000 and the refund is for 50%. And with the gold package, the total cost is £30,000 and the refund is 100%. We know that a lot of people do like the idea of multi-IVF cycles. So you're paying for cycles and embryo transfers in advance compared to the standard IVF package where the first embryo transfer is included. If for whatever reason you aren't eligible for our 2-cycle package, you are very welcome to look at a standard 2-cycle package. It doesn't come with a refund guarantee, but it does mean that all of your embryo transfers are included in the price until you reach 20 weeks pregnancy from the treatment. So it's nice to have that fallback. Mr. Summers mentioned, of course, we do have guarantees as well. So if you are interested in just a standard IVF package, with 6 eggs, we do guarantee you 1 viable embryo. And with 10 eggs, we do guarantee you 2 viable embryos. Now, with the next steps, we will be sending you an email, and this is going to ask for some registration details from you. So your name, your home address, a copy of ID, and if you have a partner, their information as well. This is to register you as a patient, and once you're registered, we can book in your first doctor's consultation. If you are planning to carry the pregnancy yourself, you would need to provide us a pelvic scan in the last 6 months. And if you're planning to use your sperm for the treatment, we would need a semen analysis report in the last 12 months. If you don't have these investigations, it's absolutely fine. We can book this in at our clinic, but we do need to have the investigations done prior to seeing your consultant because this is essential to creating your treatment plan. with the email that we send, of course, you are very welcome to ask us any follow-up questions if there is a question that we're not able to answer today for you, or if you think of anything down the line. And as a thank you for your time today and attending this webinar, we do want to give you a discounted initial consultation price. So you can see the prices here, but they will be in the email as well. So if you have time, Mr. Summers, we're just going to look through the questions that have been sent to us. Some of them we can see in the Q&A box, and some of them have been sent directly to me. So the first question is, are success rates lower with a male factor infertility? So for example, a 1% morphology rate.
There is an association between sperm parameters and overall success rates. Sometimes in the case of poor sperm parameters, we tend to offer fresh eggs rather than frozen eggs, because the fresh eggs have the ability to help repair sperm if they got, say, high DNA fragmentation, whereas the frozen eggs sort of tend to lose that ability a little bit. So this is where I went back to the points before, points 1, 2, 3, 4. We look at the clinical situation, and then based on the clinical situation, we might make a recommendation for a particular approach. So if you have a couple where the sperm parameters are low morphology score or low motility, we might recommend using fresh eggs, because we're obviously bringing through donors all the time, egg donors coming through constantly. And we do have a matching group within the London Egg Bank who will work with you if the recommendation is to use a fresh egg donor. But it would be a matter of actually looking directly at the reports of the sperm parameters and then making a recommendation. But there's a lot of flexibility in the approaches you can use depending on the clinical situation.
Thank you. So another question that we have is, will purchased eggs always be mature, or could some be purchased immature?
The egg bank fundamentally stores M2 oocytes or mature eggs, because they're the only eggs that can be fertilized by sperm. So we don't do in vitro maturation of eggs, for example, to boost our numbers. At the time of the egg collection, within 4 hours of the egg collection, the eggs are scored for their maturity, and then the eggs immediately vitrified if they're at the M2 stage. So yes, we only store mature eggs in the egg bank.
Mm-hmm. And then we've had another attendee ask, how far back do we go in a donor's family history?
Well, we have in-house genetic counselors. So we go back, in terms of the forms they fill in, we go back at least 3 generations. Right. But if we have doubts about something, because some genetic conditions can skip generations, we will have one of our genetic counselors personally meet with the egg donor or communicate directly with the egg donor and get a much more detailed family medical genetic history than what we normally get, which is a 3-generational history.
Okay, thank you. And then we've had someone ask if this webinar is being recorded to be shared. I do believe it is. So you can always ask us via email, just in response to the email that we send, and we'll be happy to share the recording for you. So we've had a question about how many eggs does a donor give to the bank, and how many other families might be using the same donor's eggs?
That's a question that has many levels to it. So because different donors are driven for different reasons to be donors. 10 eggs would probably result at most in two pregnancies to one family. A lot of donors will only donate 3 times, so that there are going to be other families who might have half siblings, if you will, from a single donor. But the UK regulations are, the last time I checked, was that you can only have 10 families with children from the same egg donor. So it's the same with sperm. They're regulated in the same way. But given the numbers involved and the number of cycles that egg donors do, I'll be very surprised if we ever reach 10 families.
Yes, that is the case. So there is a 10 family limit in place, and it's nice to know that that regulation is there. But as Mr. Summers has said, because of the nature of egg collections, it is uncommon that we would see donors donate more than 3 times. So it is quite rare that we would see that 10 family limit achieved. So we have one question of how extensive is the restricted donor list on the silver and gold package, and what are our options if we don't find a donor we are happy with? So I'm happy to answer this. With our 2-cycle packages, we do have a separate list of donors available on these packages. The reason for this is because they are donors with a proven history at our clinic. So the outcomes that we have had with them have been more than what we would expect with the number of embryos created and the grading for those embryos. Because a lot of our donors donate for the first time, and of course we only freeze mature eggs, but because they have donated for the first time, we just don't have this data for them to be on the 2-cycle package. So that is why it is a smaller list available. Now, patients would always have flexibility over the package that they go for, and you don't have to commit to a package until you've selected your donor. So if you find that you're interested in the 2-cycle package, but the donor that you're looking for is just not available on it, you are very welcome to move to a standard IVF package instead. Now, is it usual to take 10 eggs from one donor, or is it usually 6 from one and 4 from another? With the batches of donor eggs that we have available, they do vary between donors depending on how many eggs were collected. So some donors have 6 eggs available, others have 10 themselves if you're interested in an IVF package with 10 eggs, and other donors would have maybe 4, 6, various batches. It's not a requirement that you only select one donor for your treatment. So if you really like the idea of having an IVF package and using 10 eggs, this can be from 2 different donors. So 6 eggs from one and 4 eggs from another to make a total of 10. But we would thaw and fertilize all the eggs on the same day. Now, Mr. Summers, do we do PGTA testing at our clinic, and is it recommended?
That's another pondered question. I would say, excuse me, I would say that in general, because we're using young donors, there's not a huge benefit in doing PGTA. That's not to mean we don't offer it, because we do, and we have couples who will use it. But if you look at the data, the PGTA data on women under the age of 35, which is where we have the egg donors, you look at how well they do with or without PGTA. The pregnancy rates are actually quite similar with or without PGTA, because such a high proportion of the eggs are chromosomally normal. So I would say it's available, and some patients want to use it, and we won't restrict them from not using it. They certainly have every right to use it if they want to use it. But if you look at the outcomes, it's not a huge benefit. It could be that you'll want to be reassured that the embryo is normal and therefore reduce the risk of a miscarriage. And that's a certainly reasonable thing to take into account. So there are some women who want to reduce their risk of miscarriage by doing the PGTA step. But even with embryo tested, PGTA tested embryos, the miscarriage rate is still 5 to 10%, even with a chromosomally normal embryo. Whereas the background risk, if you're using an egg donor who's 30 years old, is only about 12%. So you could argue it's a small gain, but so it's not something that I personally advocate. But if a couple, for various reasons, their own experiences in what they've been through previously, they want to do it, then they have every right to go down that path.
Mhm. So I had some questions sent directly to me. One of them is, do we have any South Asian donors? We do. We have a variety of donors who are South Asian. So we are the largest bank of donor eggs in the UK. We have over 300 donors readily available, meaning the eggs have been collected and are frozen and stored at our clinic. All of our donors, the egg collections actually happen in the UK. So they're all based in the UK at the time of their treatment. But because this country is so diverse, that is why we have a variety of nationalities. I know perhaps last week, I believe it was, we uploaded 4 South Asian donors. So definitely do register on the database. We would always recommend that you apply filters one at a time. So if you just apply the ethnicity and the nationality first, you can get an idea for how many donors we have that meet that criteria, and then you can start to apply additional filters from there. I've had another question of whether we transport eggs externally. So we do. We can export eggs to certain UK clinics, but only if we have a third party agreement to do so. If this is something you are interested in doing, then let us know what clinic you would like to export the eggs to. If we don't have a third party agreement, we can look into creating one, provided that the clinic of your choice wants to. And if not, then we can do the whole treatment for you, of course. So we can create the embryos and we can also do the embryo transfers. So I have another question of how many eggs do you recommend I purchase if I only want one embryo?
Well, I think you have to go with the odds, and I think you'd be fairly safe with purchasing 6 eggs to get one embryo. But it's if you look at fresh eggs, for example, historically, I wrote an article about this quite some years ago, and when we ran the numbers, and because we have couples who do fresh IVF with their own eggs, and they don't want extra embryos, they just want to have one to put back and feel satisfied. And if it works, great. So you could go with, obviously, theoretically, you could just go with one egg. You could purchase one egg, right? If it fertilizes and creates an embryo, then you've got your one embryo. But biology doesn't generally work that way. And if you look at the data on fresh eggs, you need about 4 eggs to get a high probability of one good quality blastocyst. So I would say that's 6 eggs. But I say that because it's biology, there's no precise number. You could have 6 eggs and you could end up with 4 embryos. So that's the unknown. But I certainly wouldn't go with 10 eggs if you only want one embryo. But maybe you should just purchase 4 eggs. I'm sure that there'll be an allowance for that from the egg bank if you wanted to.
Yes, so we have a minimum number of how many eggs you can purchase based on this data for what would lead to at least one embryo. So when you're looking at fresh eggs, the minimum number is 4. When you're looking at frozen eggs, it's 6 as a minimum. Now, we have a question about, would we transfer 2 embryos at once? Is this something we could allow?
Generally, we would not put 2 back if they were top quality blastocysts. The reason is that if you have good quality blastocysts, the pregnancy rate does not go up. You don't double the pregnancy rate if you put back 1 versus 2. The only thing you risk is a twin pregnancy. A lot of our recipients are over the age of 40. And therefore, by definition, in the UK, they are a high-risk pregnancy because they're over 40. And then you put in the twin pregnancy risks. We normally would not put 2 embryos back. The The exception would be if a couple had, say, four embryos and they put one back and it didn't work, they put one back and it didn't work, and they had two left. And the quality was poor quality because we tend to put the best embryos back first. There might be a situation like that where we say, well, we can put two back. But the policy is, and the HFEA regulations are really quite strict on this, that you should really just put one embryo back if it's a good blastocyst.
Of course. So we have about 10 minutes left for questions. So we have some about the processes. One question is about how we assess the two-cycle eligibility. As I mentioned, this is something that is assessed by our London consultants. It'll be based on uterine factors, semen quality, but also a holistic view of your medical histories. So because of this, we don't really have kind of a set criteria. It is evaluated on a case-by-case basis. Now, what information can you see when picking a donor? So initially on the profiles, you will see demographic and characteristic information such as hair color, eye color, skin tone, education, nationality. And then from here, you can create a short list of donors that meet what you're looking for. We have a wonderful matching team that would assist you with selecting your donor, just so you have that support. And one thing that they can do is offer free photo matching. So you cannot see a photo of the donor because legally they have to be anonymous at the time that you select them, but you can share a photo of yourself alongside the list of donors you're interested in, and our matching team will be happy to review the photo that you have sent and compare it with the photos of the donors you're interested in, so they can comment on your physical similarity in greater detail. So if we have more than one fertilized embryo, can we freeze this and donate later if we choose not to use the embryo? Do you want to answer that, Mr. Summers?
Yes, we do recommend any what we refer to as supernumerary embryos. We would recommend freezing because you can never predict how an individual or couple's thoughts might evolve over time after if they have a successful treatment cycle. So yeah, we will all good quality blastocysts will be vitrified in any treatment cycle. So yes.
Yes, so you have the option of a fresh embryo transfer, and then any surplus embryos created, we would freeze them and store them. Or you can choose to create and freeze all of your embryos on the same day and then have only frozen embryo transfers. Freeze and surplus embryos is part of the package cost as well as the first year storage for it. Now, I have a question on if you do not find the donor that you're looking for, but you have already paid, do you get a refund? So you do need to pay for your initial appointments, like your investigations and your doctor's consultation, but you do not pay for the package cost until you have selected your donor. So you do have that flexibility. If you do decide that you don't want to go ahead with treatment with us, but you have had your doctor's consultation already, we wouldn't be able to refund the cost of that appointment alone, but we can always provide you consultation summary letters, reports of the investigations that you've done, so you can use them elsewhere if you choose to do so. And then finally, can you use frozen sperm already frozen at another clinic? And does frozen sperm impact success rates? Do you want to talk about the success rates first with that?
Yeah, it goes back to the point I made earlier, is that frozen sperm, be it surgically extracted sperm or just frozen sperm from from a sperm bank, does not perform as well as a fresh sperm from a fresh ejaculate. And for the arguments I made earlier, is that when with vitrified eggs, they lose part of the capacity to repair damaged sperm. And this would be a situation where, once again, we would think more along the lines of using a fresh egg donor with frozen sperm, as opposed to frozen eggs and frozen sperm.
Mm-hmm. And we can use frozen vials of sperm from external clinics. So, for example, you can purchase donor sperm from external clinics. If you don't already have donor sperm in storage somewhere, you may want to look at the London Sperm Bank, which we are connected to. In this scenario, you don't have to pay for the transportation because we're all part of the same clinic, which is the London Women's Clinic. But you can also look at other sperm banks and then transport them here. The same goes with your own sperm that has been frozen from previous treatment. So we're happy to do that for you. There's also a question about what should you look for in a donor besides the physical characteristics. The matching team would be really helpful with this if you want some guidance. In terms of looking for donors that are clear of genetic conditions, so we do have donors who are carriers of genetic conditions. You can decide to not choose a donor who is a known carrier, but it can be very common to be a carrier in society. And if you are using a donor who is a carrier, what we would do is test whoever is planning to use their sperm for the IVF treatment to ensure that they are not a carrier too. This is free of charge. If you're using donor sperm, you should already know the sperm donor's carrier status as well. So that's where the risk lies if they are both carriers of the same genetic condition. And if we know that, we wouldn't allow you to go for treatment with that sperm and that egg provider. Instead, one of them would have to be changed. But as Mr. Summers mentioned, we do have a geneticist in the clinic if you have any questions. So I think that is all we have time for in terms of the questions. As I mentioned, an email will be sent to you. So tomorrow, if you do have any follow-up questions, then do feel free to send them to us. We'll be more than happy to get back to you. Alternatively, if you are in a position where you know you want to go ahead and register as a patient and book in your appointments, do just respond to the registration details that will be sent in the email. So respond to them via email and someone from our patient care team will be in contact and we can get you booked in. So thank you for your time this evening to everyone, as well as to yourself, Mr. Summers. I do hope you found this webinar informative and do let us know if there's anything we can do tomorrow. Okay, thank you everyone.